what is the observation? The main thing is the lower plane is steep, curve deep curve on both sides. It's kind of a deep weight patient is having, and the vertical maxillary excess maybe along with the bimax protrusion. Since the patient was having excess vertical maxillary excess, the denture also is not looking good because they cannot set the teeth at a correct incisal plane. After extraction, if they have done alveoloplasty, a good aesthetic result. So, if you are planning for implant, we have to go for a lot of alveoloplasty. The important question is how much and from where to where. Okay. We don't know about the premolar canine molar areas. So for that we need lateral smile photo without the bridge. And a wide possible wide smile photo we need. So we need a wide smile frontal and right lateral, left lateral all.
Without denture also.
Without denture. And another problem when we are taking lateral profile is this area should get captured. But actually we are capturing this area. So we couldn't able to analyze how much exposure the patient is having when smiling. So we are taking lateral smile photo, but it can be improved. So patient is above 40, right?
40, sir.
Sure. So the patient would have accustomed to this full appearance. So when we are doing alveoloplasty and when we are giving new tooth, they may not accept the sudden change in the face. So we have to give the tooth little bit of the proclining position. So those things we should discuss with the patient during jaw relation. Right? So almost like 3 to 4 mm excess. After that 2 mm we have to reduce to bring the junction below the lip. Okay. And if you see this photo, there is one important. Yeah, this one. There is a deep fold here. Right? Whenever there is a proclination of the maxilla or tooth, whatever it is, the lip, when the patient is smiling, the lip goes beyond the prominence. This fold comes. Okay. So this is an important document. So post-surgically, also the patient may have this, and the patient may tell, I don't want this fold. But, so you have to discuss it with the patient before that change. Okay. Between the upper lip and the nasal.
That is not because of the dentures flange, sir.
That may be one reason, or it may be the natural anatomy. Some patients they have this fold here, right? We don't know unless we do it. So the flange is fully covering the palate?
No, sir, horseshoe shape.
Okay. So it's a classic, cover spleen. So denture with the anterior, lower anterior ceramic tooth is a recipe for severe bone loss in the upper anterior area. But if you see the panoramic view, there is good height is there, right? But we don't know about the buccolingual thickness. Of course, we have to do a lot of alveoloplasty, right? The left side sinus is much worse than the right side, right? We will see this. See, she might have got short upper lip. So we have to measure the upper lip length. Look closely. The VD vertical dimension looks more. Usually the vertical dimension will be less for FMR patient before treatment, but here the VD is very less. So immediately after post surgery, if you see, the face will reduce in height, or it will become normal in height. Is the patient having any TMJ issues? Because the prosthetic space is less, the competenture might have been given in an increased VD. So you have to ask for any TMJ sound, clicking sound, pain, tenderness, any headaches. Headache, no, not possible. But without denture, what is that? See the difference, no? This is without denture, right?
Without denture.
No, this is without denture. But here the lips are competent. So post-surgically she will become like this one. And this lower lip may go a little bit inside because we will be solving this propionation, right? The main problem is this area, right? If they have done a alveoloplasty and given a complete denture, aesthetically it will be a satisfactory, So we see lower first. From the axial view, it looks like as a very osteoporotic mandible, right? Already the patient was having lower anterior tooth exposure is more. So we have to bring the lower incisor position still more down. So we have to do a lot of alveoloplasty. So all this kind of vertical maxillary excess patient, they will have this anterior mandible height very too much. This height also will be very low. So the height is good. We don't know about the vocal level. We will see the from right side. We will see. We will find the metal foramen first. Okay. Metal foramen is just above the second premolar, right? Even here we can place a implant. Okay. But we will move in the second premolar. So first straight implant. Bone quality is not that much bad, right? You will see the 360 degree view. Yeah, you can see, it is closer, right? Can you see this is a metal nerve exit, upwards, outwards, and this way. So either you have to choose a shorter implant or tilt it message. But I prefer not to tilt. Why? Because
abutment will go.
If you tilt, you have to bend it. The bone is very soft, so you cannot bend. The implant will move through the bone. Bending won't happen. So better choose a shorter implant. Anyhow, we will be doing alveoloplasty here, right? So we will be using a very short implant, maybe 10 mm implant. So whenever you find osteoporotic bone, place all the implants straight, no tilting. If you tilt, then you have to bend the abutment, then it is not possible to bend the abutment of the implant body itself will move. So here a shorter diameter implant we need to place, right? 3 points something. Here the anatomy is good actually. And here we will be doing alveoloplasty, right? This much amount of will measure it. From 6 mm alveoloplasty. Even after 6 mm alveoloplasty we can Placing 16 mm. Okay. Here also it is very thin bone. Very thin bone. Actually, simpler and 3.2 to 15 is ideal for this kind of situation, because the diameter is very thin. Simpler and 3.2. See, with even with violent 3.3 is there. Okay, 3 mm also will be there, right? But simpler and advantages. What is the advantage?
Basal.
No, compressive one. KOS. What is the advantage of using 3.2 simpler than violin nowadays in this situation? The advantage is the top crestal few threads are smooth surface. So even if some bone resorption is happening because of the thinness, it is not an issue. But if it is a totally rough surface, no, from the crest, if there is some bone resorption after 2 months, 3 months here, then it's not good. So KOS, the top few threads are smooth surface. Have you seen? No. Okay. Next one. Why we are using thin implant here? Because the bone itself is very thin, there is chance for any bone resorption in the crest. So better to use it. Not only thin implant with crestal threads, smooth surface. This is almost in the first premolar. The bone here is good, no? Some cortical bone is there. We don't have to go beyond this cortical bone, right? Anyhow, we'll be doing some radioplasty here. So it is only 10 mm implant in the second premolar, right? Post radioplasty you will get less bone. You will see the mental foramen is very far away. No issue. See, no? If there is a distance between the mental foramen. We will just see above the mental foramen. A very short implant we can place. However, we are not going to choose this area. This is the mesial aspect of 6. See, the bone is very much
Osteoporotic. Osteoporotic.
It's very much osteoporotic, very thin bone. Totally.
Why not basal in this situation, sir?
This is a very bad choice here. Because basal depends only on the
Cortical.
crestal threads. Here, where will you engage the crestal threads? Which is buccal. This is buccal, right? Lingually, there is no undercut or myloid ridge because it is a premolar. Sorry, molar. If we go slightly distally, we are getting this lingual cortical. You can engage. Here you can use a basal design. Here you can use a even compressive design also you can use. So you will get good stability. So definitely we have to engage this bone for this patient, because everywhere it is soft bone only, right? The more you go distally, the more good undercut you are getting. So along the lingual aspect, probably 4 into 10, right? And one implant here, which will be a very less stable implant. Okay. By splinting, it will also integrate later. So all the implants, they are not very stable except for 1 or 2 implants. But by connecting them together, they are working. So we will check the mesial root. See, somehow because the force is going through this 6, the bone quality is good. Anteriorly, no tooth, no work, no bone. Here, some work is going, so the bone quality is good. But because of periapical infection here, there is a cyst here. So either we can choose the mesial, yes, 4-6. But we don't know which canal. Yes, this is the canal, right? Maybe a very short implant we can place 8 something. And we can place the interdental bone. Or one more technique is just try tilting it slightly easier. Not much. Okay. Either place a short wide implant in the mesial root or in the interdental area. And we'll check the internal area of between 6 and 7. Here you can place a short implant, probably 4.28, engaging the lingual cortex. Okay. Avoid going beyond the distal root of 7 and all, better to avoid access, everything. So it's easy to plan in the simplicity, but transferring that plan clinically, it's unnecessary. We can get good bone support here from the mesial edge of the 7 socket. That is ideal. So by this plan you can give 7 also later. Include 7 also. So the plan. So now you understand where to select compressive, where to select basal. Some simple principles are there. One principle is, if you use basal, the apical threads should engage in a good cortical. Right? That is one principle. So wherever you are getting good cortical, you can place a basal region. So that means in the mesial root of 6, basal is not a ideal choice always, most of the time, because there is no undercut there, there is no myloid ridge there.
But sometimes we place basal in anterior region now, sir. That how you have
Because the anterior mandible itself is cortical, not necessarily you have to go till the lower border. The entire bone is cortical for many patients. But even some patients, the lower anterior bone is totally osteoporotic. Yesterday we did lower anterior, no? The lower anterior is fully osteoporotic. That means it's better to use a compressive. But labily there is bone defect is there. If you use a compressive implant or a conventional implant, labily the threads will be exposed and the risk of periimplantitis or recession or using bone graft. So that is why we use the BCZX, so which gets stability by good compression and which is also a smooth surface implant. So even if some bone resorption naturally happens, it doesn't affect the longitude of the implant. If you remember a CLDC patient yesterday, lower anterior, I have shown the BCZX, the crustal threads are exposed because of periodontal, but the implant is stable, no periimplantitis. We will see the upper one. So when we are planning the upper, we have to keep in mind that we are
doing areoplasty.
Yes, areoplasty. So this kind of vertical maxilla, as you can see, this anterior maxilla is too prominent. So we will be doing areoplasty here also, this shaving. Okay. So we will be shaving maybe till the nasal spine. That is why some patients tell they have discomfort in this region, the nose region. So not only height, but also the labial. Labially also we have to shave. Imagine you are cutting it like this, vertically. Right? Will it solve the problem? No. There is a prominence here, so we have to cut it here also. So first we will plan both the pterygoids. If you see the left sinus looks not so healthy. The right sinus is good, right? But the left sinus is some sign. Better ask, sinusitis history. So here, if you go along the root, just along the root of the 8, palatal root, you will go into the pterygoid. Good bone. 4 into 16. Straightforward pterygoid. No difficulty unless you make a gross mistake. Because the root angulation naturally points towards the pterygoid area. So the socket itself acts as a guide for us. Here if you see, the root angulation is going towards the buccal aspect. So we have to tilt it towards the mesial aspect, medial. Okay. So here also you are taking the socket as the guideline, but you are going slightly medially. And angle is okay. Here also you can place it 4.2, 16 or 18. It will be in this 2 range only, 16 or 18. Okay, so 2 pterygoids done. Now, see the maxilla planning is very simple. 2 pterygoids, anteriorly 2 implants next to midline, and other 2 implants in the premolar area, if not possible in the premolar area, in the canine area. Okay, these are the key areas. Then the molar, they can save us if there is problem, difficulty in these sides. Okay, the key area is anteriorly 2 implants, pterygoid 2 implants, the canine premolar. Yes, second premolar, first premolar, canine, whatever it is. So here, after alveoloplasty, see the labial prominence we can see here, right? Even if you remove this height, here the bone will be sharp. This is what I was drawing on the thing. Okay. So here, probably 30 mm implant will do. Okay. You will see the 360 degree. If you see here, this implant is not parallel to the midline. This is the Naso maxillary, Naso palatal canal. So we are taking it. Okay. This is the Naso palatal canal. Okay. So this is the palatal approach technique, right? We are not drilling through the crest, we are drilling palatal. Okay. So here also you can see, this is the canal is quite big. Now what we are going to do is, we are going to check the implant at the canal. Okay, so it is, it is not very big, right? Because there is bone here till here, but here
No
bone, only 3 to 4 mm is bone. And sometimes from here we can drill into the bone, that is also not favorable here. Here the bone thickness is anterior to the canal. How much bone thickness is there? It is not thick here. So trying a nasopalatine implant is not a good idea. Better stick to the previous plan. Now we will be placing another implant in the 1211 area. Very thin bridge, palatal approach only. Minimal diameter implant 3.75. Compared to the left side, the bone is very thin here, right? See, there is a severe
disruption.
Concavity. This is a natural concavity in lateral area. Whenever you see this concavity, that means this is in the lateral area. So what we are going to do is, we are going to move it closer, little to the 1-1 area. The more closer you are going to 1-1, the concavity becomes less, right? So in this situation, it is better to plan implant close to the canal. The more you are away from the canal, entering the little incision zone, you are entering the labial concavity area. So do you know idea about the concavity? No? Okay. So in lateral incisor area there is a natural concavity in lateral incisor. Okay, this is okay here. This is premolar. The premolar, it looks good, right? Even if you do some malleoplasty, it is decent. Okay. We'll just try tilting it anterior. If you tilt anteriorly, we can go for the palatal to buccal approach. Okay. I'm just shifting it more anteriorly, so that we are entering the buttress area. This is the buttress area. Okay. But there is no advantage. We'll stick to this premolar plan. Again, the bone quality is good. One implant. Even we can place the additional implant in between here. You will see. No. This is enough. We'll try the molar areas. The bone is only around 8 mm. But it is not necessary because we have already placed a good pterygoid implant. Okay.
Bars?
Is bar only. Definitely bar. This is the left side is more challenging than right side because the sinus is more dominant. So from the premolar area, we are tilting it and getting engaged in the Naso maxillary buttress area. That's it. See here still the sinus, because the sinus is coming too much forward, our implant is partly into the sinus, we have to tilt slightly still more. Yes. The problem is when we mistakenly drill like this. That is where the problem is. So how to find where the sinus border is. So what we can do is we can open the flap to expose the sinus wall. By the translucency and transparency you can see the sinus. Okay. Next time you can see. This outline we can see through the bone. Okay. It will be like a paper thin here. Like a transparent sheet.
During zygoma.
Just
No, when you are doing zygoma implant, it will
yes,
be
we have
visible.
seen the same. Here the bone will look different. Here the bone will look different. Irrigate nasal saline and we can find out where the sinus is causing. Our smallest technique is just do a small window here. Use a probe to feel the sinus anterior extension of the sinus. So this is the classic nasomaxillary buttress implant, palatal to buccal approach. We have tilted it mesially, but we cannot bend the abutment much because the bone is soft. But bending is not necessary because it is a screw retained implant. So all the 6 implants are very, very critical implant's critical position. You cannot make any mistake. If I do mistake in one position, I can place implant in another. It's not like only 3 areas is only 6 locations are available. There is very less room for making any. Okay, because the bone volume is very much limited because of the sinus has occupied much of the space. From here to here, the sinus occupied. From here to here, the sinus occupied. There is some septum we are seeing here, right? We'll see it. Yes. Yeah, you can see that, no? Sinus, no septum served. But it is not of use for us. Some kind of sinus problem is there for this patient, maybe because of from the dental also. From the dental also might contaminate the sinus. But typically very soft diet, and since the bone is very much osteoporotic, definitely there will be deficiency of
Calcium, vitamin D.
vitamin D. So that is suggestion.